Bismillah ar-Rahman ar-Rahim. In this video, we will explain the inferior fornix transconjunctival approach. The typical inferior fornix transconjunctival approach can use two different routes to access the infraorbital rim, retroseptal and preseptal. These two approaches vary in relation to the orbital septum on the pathway to the infraorbital rim. Controversy exists on the advantages and disadvantages of these two surgical routes, but we recommend the retroseptal because it is more direct and easier to perform. Placement of corneal protector, that is a shield, and two or three traction sutures placed through the lower lid assists in the placement of the shield and in subsequent surgery. Here you can see the lower eyelid is everted with a fine forceps and two or three traction sutures are placed through the eyelid. These should be placed straight through the eyelid from the palpebral conjunctiva to skin, approximately 4 to 5 mm below the lid margin to ensure that the tarsal plate is included in the suture. The retroseptal route enters directly into the fat compartments of the lower eyelids. After eversion of the lower eyelid, the position of the lower border of the tarsal plate is identified. The incision is placed in the depth of the fornix. For in the incisions, you can use scissors, scalpels, or electrocautery. When using scissors, the conjunctiva is elevated laterally with a fine forceps and in size over a distance of about 8 mm, including the lower eyelid retractors. What are the lower eyelid retractors? Basically, the lower eyelid retractors are facial extension of inferior rectus muscle, and its incision have no clinical concern. Starting from the initial transconjunctival incision, the conjunctiva and the lower eyelid retractors are undermined towards the inner angle of the lids. For this purpose, you can use the initial incision for the lateral canthotomy, and with the help of spreading scissors, you can undermine this area. So after undermining, you are behind the septum. So what will you do? Then the incision line is extended from laterally to medially to expose the fat compartments behind the orbital septum. Here you can see a sagittal plane through the orbit in globe, demonstrating level and plane of incision. The conjunctiva and lower lid retractors are incised with the help of a scissors. Alternatively, as we said, that you can use the scalpel or electrocautery incision. Here you can see a scalpel shown here for incision. The lower lid is retracted downwards. Here you can see retracted downwards to expose the periorbita or periosteum just behind the edge of the infraorbital rim. Here, this is a infraorbital rim, and this area is just behind the infraorbital rim. If it was decided to suture the posterior edge of the conjunctival flap to the upper eyelid as a corneal protection, then this should be done now. Next, the periorbita is incised just posterior, as we said, just posterior to the infraorbital rim. Here you can see another view that the periorbita is incised parallel but just posterior to the infraorbital rim. Once the infraorbital rim is exposed, the periorbital dissection can be performed in the usual fashion. Here you can see the clinical photograph showing the incision and dissection of the periorbita. Closure of periosteum or the periorbita is not possible. The conjunctival incision is closed with a running 6-0, a fast absorbing suture. The suture ends may be buried or guided transcutaneously to bury the knots. Now come to the preseptal root. The preseptal root requires entering the suborbicularis oculi, preseptal space above the fusion of the lower lid retractors and the orbital septum. This eyelid has been averted. Otherwise, this area is, you can say, above the fusion of the lower eyelid retractors and the orbital septum. This allows basically direct visualization of the septum. Now, after vasoconstriction and insertion of corneal shield, 2 or 3 traction sutures are placed through the lower eyelid as we explained in previous slides. After eversion of the lower eyelid, the position of the lower border of the tarsal plate is identified, similar to retroseptal approach. The posterior edge of the conjunctiva is tented and secured with a stay suture, and traction is applied to lift the conjunctiva while lid margin is everted. The lower border of the tarsal plate is raised in this manner. The incision is made directly below the tarsal border and suborbicularis oculi preseptal space is entered. The incision is made using fine scissor. Here you can see a fine scissor starting from laterally or scalpel. You can also use a scalpel or electrocautery, and hemostasis is achieved with a bipolar coagulation. Now, blunt preseptal dissection is performed until the infraorbital rim is reached in the supraperiosteal plane. At this point, the corneal shield, shields are removed and the cephalic edge of the conjunctival flap is pulled up to be sutured to the upper lid for corneal protection, as we explained earlier. Once the infraorbital rim is exposed, the periorbital dissection can be performed in the usual fashion. In the preseptal approach, the periosteum over the periorbital rim can be closed. The transconjunctival incision is closed using a 6-0 resorbable running suture with the suture ends either buried or guided through the skin externally to bury the knots. An accurate alignment of the conjunctival flaps must be guaranteed. Thank you.